To the second seminar of the newly relaunched Bradford Hill series, which is the joint seminar series of the three population health sciences groups here at the University of Cambridge, i.e. the MRC Biostatistics Unit, the MRC Epidemiology Unit, and the Department of Public Health and Primary Care. It's my great pleasure to introduce today's speaker, Professor Ben Cowling. Professor Cowling is the Chair in Epidemiology at the University of Hong Kong's School of Public Health and Head of the Division of Epidemiology and Biostatistics. He is also co-director of the WHO Collaborating Centre for Infectious Disease Epidemiology and Control at Hong Kong University. Professor Cowling's primary research focus is in infectious disease epidemiology, particularly for respiratory viruses, including influenza and SARS-CoV-2. I am delighted that he has joined us today, and he will be talking about his work on the epidemiology and control of COVID-19 in Hong Kong. Thanks, Ben, over to you.
Thanks very much, Anne. It's my pleasure to share some work with you today. Let me do that. So I live and work in Hong Kong, but I just happen at the moment to be visiting the United Kingdom. Work is still very much ongoing in Hong Kong. In the next probably 30 or 40 minutes, I'll share some of my work, some early work, which was done 2 years ago, and then some work over the last 2 years on what's been happening in Hong Kong, how Hong Kong's done well, particularly in keeping COVID under control for 2 years, the vaccines that we have available in Hong Kong and some vaccine-related research. And then finally, the current situation in Hong Kong, which is unfortunately not so good after 2 years of doing fairly well. So one of the first studies that my colleagues and I were involved with was a collaboration with the Chinese Centers for Disease Control and Prevention. We went up to Beijing, I think on about the 21st, 22nd, 23rd of January. Actually, no, it says at the bottom, 23rd of January. So we were there towards the end of January. We were able to work with them on the early investigation of the outbreak in Wuhan, and we published a paper very, very quickly. It's one of the fastest publications I've been involved in, where we wrote the paper over the weekend, did the analysis and wrote the paper over the weekend, and it was published online in the New England Journal of Medicine in the middle of the next week. Very, very rapid publication, which I think was helpful. We reported some important information that the epidemic was clearly increasing in terms of incidence. We estimated the reproductive number of 2.2 in December, before there were really control measures in place. So that was really an R0, where in other parts of the world, typically that there was some degree of population behavior change in the early days of the epidemics. We had a mean serial interval estimate of 7.5 days and an incubation period of 5.2 days. And those estimates, I think, have held up pretty well. We also looked at severity and had a paper published soon after in Nature Medicine, looking at the case fatality risks. And again, I think these estimates have held up fairly well. Symptomatic CFR of 1.4%. Of course, we recognize there were infections that were not detected. So of course, the infection fatality risk is lower, but we saw very clearly at this point that the clear difference with age, where older people are really the most vulnerable, drastic changes in risk of severe disease by age. And then one of the other, I'm just going through the greatest hits to start with, sorry, it's a bit of a ramble. One of the other really important findings very early on was the existence of pre-symptomatic contagiousness. And in the early days of the pandemic, if you remember, there was a report from Germany of pre-symptomatic infection in a business meeting, and it was a letter in probably Lancet or New England Journal of Medicine, and it was in the news, and then the letter actually got retracted or corrected. But we were able to analyze some systematic data collected by China CDC and also collected by ourselves and Guangzhou CDC. And we were able to provide an estimate that actually a lot of infectiousness, a lot of contagiousness was occurring before symptoms began. And that makes COVID particularly difficult to control using targeted methods like isolation of cases, like stay at home when sick or isolate cases when sick. because transmission may have already occurred by that point. So you have to go one step further and do contact tracing and quarantine of contacts to try and get ahead of the virus. But one of the most interesting findings, I think, maybe something quite novel, was we looked at serial intervals in mainland China. The serial interval is the time interval between onset in one case and then the onset in another case that's an infection from that first one. So if person A infects person B, then you look at the symptom onset in person A, the symptom onset in person B, and the difference there is the serial interval. And one of the very strange observations we had in the early days was that sometimes serial intervals could be negative. So even if A infects B, the symptom onset of person B could be earlier than the symptom onset of person A, which sounds a bit strange, but it can happen. And we're fairly confident that it has happened a number of times with very clear evidence. What we did in this particular study was look in Wuhan at the course of the epidemic. The numbers were rising through January, and they peaked around the time of the end of January, when the lockdown in Wuhan had been in place by that point for about a week. And then the case numbers started to come down again. And what we identify is actually the serial interval distribution was changing. We have this idea quite often that biological parameters might be fixed, the incubation period might be fixed, the viral shedding profile might be fixed, and so on. And while there is something underlying those that's fixed, the serial interval in this particular case changed, the serial interval distribution changed over time. And it's kind of interesting. It started at about 8 days on average. The average came down to 6 days during the peak. And by the fade out of the epidemic, or the control period of the epidemic when numbers are coming down, the serial interval was much shorter, only 3 days on average. And we attributed that to the control as isolating symptomatic cases and also quarantining their contacts and really limiting particularly the right-hand side of this distribution more than the left. So if you can stop symptomatic cases from spreading, then of course all that's left is the pre-symptomatic transmission. We thought that was kind of interesting, and there hasn't been such a lot of thought in the past about how some of these distributions might change over time. There's another issue called epidemic phase bias, and I'll talk about that a little bit later. That's when cases in the early part of the epidemic are somehow different to cases later in the epidemic on average. This is a different kind of issue, and it's attributable to control. In Hong Kong, where I live and work, we did fairly well in the early days of the pandemic, keeping case numbers to a fairly low level. And this graph is the first 100 days, the experience in the first 100 days, Hong Kong and Singapore to the lower right of the figure. A lot of other places have this steady exponential growth, of course, which we know about, doubling every 3 days. So we did fairly well, but the authorities in Hong Kong and also in Singapore hit on a particular strategy which has then carried over for at least the first 18 months of the pandemic, once it got working properly. And that strategy is now called dynamic zero COVID. In New Zealand, they have another name for it. In Hong Kong, it used to be called zero COVID, and then they changed it to dynamic zero COVID. In Singapore, they may have had another word for it as well. The concept is local elimination. So understanding that the virus will still be in other parts of the world, but domestically trying to keep numbers as low as possible. And it's a little bit different to the strategies in other parts of the world where there were clear public health efforts to reduce transmission and reduce case numbers, but those measures were relaxed once case numbers got to a low level, and sooner or later the numbers rebounded. The idea of zero COVID is to get all the way to zero and then stay at zero for a period of time. And in Hong Kong and Singapore, it was done fairly well. In Australia, there was an issue with finding it difficult to get all the way to zero and having to have the outbreak control measures in place for longer. So there's two phases, and that's why it's dynamic. You switch between the outbreak control phase. When there are cases, you've got to get on top of infections, stop transmission, get to zero as soon as possible. And then the other phase is when you're at zero, you've got to try really hard to stay at zero. And of course, the border controls are really critical. So that means probably reducing the number of travelers because risk is going to scale with number, and also being very careful in how travelers are managed. And in Hong Kong, we had 14-day hotel quarantines for a period of time. We had 21-day hotel quarantines. I myself did a 21-day quarantine the end of last year. And so in a hotel room, and you can't step 1 foot outside the door of the room while you're in that quarantine. So very, very strict. The rationale is that while the travel measures are inconvenient and costly, COVID is also a big issue, particularly before vaccines are available. And the zero COVID strategy, by allowing a return to normal domestically, when you have 0 local cases, a return to normality domestically has a lot of advantages. And I think that there's a discussion to be had about the pros and cons, but there are clearly some advantages for zero COVID. So in Hong Kong, this is the situation for the first 2 years. The epidemic curve is at the top of this slide. And by the end of the second year of the pandemic, by the end of December 2021, we had about 1.5 confirmed cases for every 1,000 persons. I'll show some serologic data in a bit, but we didn't miss too much. So we had here on the top figure, three community epidemics, each one slightly larger than the previous one. Strangely, it's not called the first wave, second wave, third wave, because in the very early days of the pandemic, we had importations of infection from mainland China. And then the March wave was triggered by importations from Europe and the US. So actually in Hong Kong, they call the first part the first wave, where there weren't really any wave, but it's called the first wave. And then the March to April is the second wave. July and August is the third wave. November onwards is the fourth wave. And just right now in Hong Kong, we're having our fifth wave of COVID. The 4 waves shown on the slide here were all with a virus like the ancestral one. It wasn't a variant. We didn't have community transmission of a variant in this time period. So the basic transmissibility in Hong Kong, we think basic reproductive number in the range 3 to 4, but we had a lot of control efforts from the early days. We had universal masking throughout. We had pretty good test and trace that struggled at the peaks, but we did a lot of isolation of cases in hospital. So all cases are isolated in hospital. There's a contact tracing team, which goes looking for people who may have been exposed to the virus, and those contacts have been quarantined in hotels or in purpose-built facilities, something like a holiday camp, specially designed to hold people for a 14-day or a 21-day quarantine period. And the targeted measure of test and trace has certainly helped to reduce transmission, but it wasn't enough to stop the community epidemics, the second wave, third wave, fourth wave, because it was in place and we still had rising numbers of cases in the start of those waves. And it was only when moderate social distancing was introduced that we were able to see the reproductive number come down below 1. In the fourth wave, the reproductive number only barely came below 1. And the kind of social distancing measures that we had in Hong Kong were not total lockdowns, but school closures, work at home policies for civil servants, but also many private businesses follow suit. Reduction in large gatherings and large groups, not only outdoors but indoors, closure of certain facilities and seating restrictions in restaurants. So those social distancing measures worked in the second wave, the third wave, the fourth wave. We're able to get transmission under control each time and get the numbers back down to 0 between each of those waves. And then we had a good period of time between May and December 2021 where there was no community epidemic. There were a handful of cases caught in the community, but no major transmission, no major spread in the community. So that was really the good side of zero COVID, I would say. In that entire period, very few severe cases, of course, because the incidence is so low. We did identify, though, this is data from our regular telephone surveys through the pandemic. Most weeks we do a telephone survey with either 1,000 people, in some weeks just 500 people, and we've kept that going even until now. So this is in the first year of the pandemic, looking at people's responses in terms of their social distancing behaviors, and we saw clear evidence of response fatigue between the third and the fourth waves in terms of government advice to avoid going out and avoid crowds and so on. And that did have implications for the control of the fourth wave, where I think we barely got the fourth wave in Hong Kong under control, just about managed it. But it also has implications for any subsequent spread, because the fatigue may still be there, even after a period of time with lower incidence. We repeated the analysis of serial intervals in Hong Kong. The previous one I showed you was data from mainland China. And we saw again in Hong Kong, the red bars before the peak, during the peak, and after the peak are shown in each of the waves, the second, third, and fourth waves. And we can see the red estimates of the serial interval coming from 5.5 days in the second wave before the peak, and then coming down to 4 at the peak, and maybe 3 after the peak in the second wave. It's kind of interesting that we see the same phenomenon consistently with what we saw in the data from mainland China. We also wanted to know if it was mainly attributable to the more timely isolation of cases. And that was true in the second wave on the left-hand side of this figure, where the blue are the onset to isolation intervals. And they did come down over time, indicating we were getting to cases more quickly, isolating them more quickly, but still not that quickly. Even at the end of the second wave, there was an average delay of almost 4 days from when a case had onset to when they were isolated. In the third wave, though, we don't see the same pattern. That's kind of interesting. So we're still wondering, to what degree is the rapid isolation of cases responsible, or what about social distancing or better awareness of infection as a way to explain why the serial intervals changed. And then in the fourth wave, because we had this up and down, this resurgence actually in January, the pattern is a little bit stranger. So we're still working on this, actually trying to think exactly what's going on and doing more analyses from the kind of data that we have. And because of the contact tracing that's done in Hong Kong, we have very rich data on chains of transmission. And one of the studies we were able to do was to look at super spreading. And this is a phenomenon where a smaller fraction of infected people are responsible for relatively more of the transmission that occurs. And for example, there are large clusters of infections occur from time to time, but there's also many cases who don't seem to spread to anyone at all. And so the figure on the left is the cluster diagram from our second wave, where there was one particularly large cluster and then a few smaller clusters, and a lot of small outbreaks that were identified with contact tracing. Now, of course, all of these cases ultimately could be linked together, most likely, but we can only link together the ones that were linked by contact tracing. So we're missing some of the linkages, we know that, but that can be accounted for in the analysis. One of the interesting things I'd like to point out on the figure on the left is we also know who was quarantined. And so those are shown in the cluster diagram by the circles with boxes surrounding them. So the box around a circle means that was a person who was confirmed after they entered quarantine. And because the quarantine in Hong Kong is strict, that should be a terminal node. That should be the end, that person cannot spread any further because they were in quarantine, in theory, when they became contagious. That's the concept of the contact tracing and quarantine anyway. And we see that there's quite a number of terminal nodes in quarantine. And of course, if quarantine hadn't been done, those nodes may not have been terminal nodes. But at the same time, there's many, many nodes which do not end in quarantine. That's people who were not found in quarantine. They were found in the community and they had not passed on infection as far as we can tell. Certainly, we can be confident they didn't cause large outbreaks. There may have been some unknown spread, but it's kind of interesting that there's plenty of terminal nodes that didn't end in quarantine. And the thing that I'm particularly like to point out is in the middle of the first panel, the lower right of the B cluster. This is a bar cluster. There's a yellow circle with a square around it and a superscript 1 leading to a turquoise colored node. And that was the one occasion we're aware of where transmission occurred prior to the person entering quarantine. So the quarantine was too slow in a way. A person was quarantined. They were only confirmed after they'd entered quarantine, not before. They were tested before, but not confirmed before, and they transmitted to a family member before they were quarantined. And so that would be, if that happened more frequently, that would be a justification for going 2 steps in contact tracing. So to trace the contacts and the contacts of contacts. That hasn't been done in general until fairly recently in Hong Kong, where we have seen that being done, particularly with variants, where not only close contacts are traced, but their contacts also are traced and quarantined. And that's a pretty stringent approach. Now, sorry, on the right-hand side of this figure is the offspring distribution, where we see 70% of cases didn't transmit infection to anyone else, as far as we can estimate, and 19% of cases are responsible for 80% of transmission events. So that's classic super spreading. There's in other infections, there's a theory it could be 20, 80, something like that. In this particular case, it was 19 to 80. What we've done since then, this was 2 years ago, what we've done since then is look in more detail at this parameter K. This is the overdispersion parameter in a negative binomial distribution, and K below 1 is overdispersed. And in this analysis, we estimated K, but what we've done now is looked at whether K varies over time, and it turns out that it does. And so this is quite new work. We're just uploading a preprint at the moment, actually, on this particular analysis. So I'm showing on this slide the second wave, the third wave, the fourth wave. The top panel is the reproductive number, and when the numbers, the higher level, that's when there's more transmission in the community. So we're including the early, middle, and the late phase of each epidemic in these panels. And interestingly, we see K tends to decline over time. Now, we had a theory when we were starting this analysis that controlling super spreading events and preventing super spreading events would be one of the ways in which COVID transmission can be stopped. Because if you can stop the small fraction of people super spreading, so if there's occasionally a case who would spread infection to 20, 30, 40, 50 people, if you can stop that from happening by preventing large gatherings, then you've got all these other cases that don't spread to anyone anyway, then you're going to do a good job in control already. But what we found is, in contrast, we didn't see less super spreading as the epidemic progressed. We saw more. And so the bottom panel here is the estimated proportion responsible for 80% of transmission. And for the second wave, the bottom left panel, that's the 19% I showed on the previous slide, and it doesn't change that much. But the third wave and the fourth wave changes quite substantially, from more than 20% of cases responsible for 80% of transmission, the early days, down to 10% of cases responsible for the majority of transmission. And what we think, and we're still looking at this, what we think is it's actually the other side of the offspring distribution that's really driving this. So it's not so much that there wasn't large outbreaks, there weren't large outbreaks in the later phases of these epidemics, but there were a lot more terminal nodes as the epidemic progresses. And there were a lot more people who didn't spread to anyone else. And that's with the contact tracing, the quarantines, and the social distancing, meaning that there's more terminal nodes, there's more zeros in terms of the onwards transmission. And that may be underlying this pattern. But I think it's fascinating. That's, again, we think something like K could be relatively constant, and it turns out it's not. And now I'm starting to think, what other things did I think were maybe constant and actually are not? And it's really a fascinating area. Now, the other bias that I mentioned earlier is called epidemic phase bias. And this is an issue when you look at something that's happening in an epidemic, whether it's an incubation period, a case fatality rate, or in this case, a viral shedding pattern, the cases that you tend to see early in an epidemic, this is at the top panel, the cases you see early in an epidemic tend to be people who've been infected fairly recently, because there aren't so many people who were infected earlier. Whereas in the later phase of an epidemic, on the right-hand side of the epidemic curve, there's no longer so many recent infections because incidence is declining, but there's plenty of older infections. And so you have this different case mix. And for incubation periods, it means that you get apparently faster incubation early in the epidemic and slower incubation later, but it's just this phase bias. And for viral shedding, for CT values, people who are earlier in their infection have higher viral loads, lower CT values. And so we can use that as a marker of how the epidemic's going. A very nice paper by James Hay and colleagues in the US and UK, published in Science, explaining this concept. And they had an example, I think in nursing homes, maybe in US. What we're able to do in Hong Kong, because we have complete data on all the cases. As I told you earlier, every case in Hong Kong in the first 2 years was hospitalized for isolation. And of course, they're tested on admission and afterwards. And we get the CT values. It's recorded in a database that we're fortunate to have access to. So we can look at the changes in CT values over time. And what we see here, that the top panel is the RT that we use other methods to estimate. The middle panel are the CT values, the average CT values. And the bottom panel is the skewness, which is the how the CT value distribution changes in terms of its skewness. And it's very consistent with James Hay's hypothesis from that Science paper. So we're kind of, in a way, we're able to validate the whole concept at the population level. In the paper that's just coming out very soon in Nature Communications, we show that by using the CT values, we can get a more timely estimate of the reproductive number than we can do by just using the case counts. Because when you estimate the reproductive number with case counts, you have a delay. You can only look in the rearview mirror at what was happening a week ago. But with the CT values, you can get a little bit closer to real time. Of course, it's still not quite real time, but it's a little bit closer. And so we looked at ways to do it, and it seems to work pretty well. And we're wondering now whether we can use it in our current Omicron epidemic in Hong Kong. But of course, with Omicron, the viral shedding changes. So that's our next problem, is how to rescale this kind of pattern to use when there's a variant with a different viral shedding pattern. And another idea would be how to integrate multiple sources of information together, so CT values and other things as well. There's really, really fascinating. Now, we're doing a number of community studies in Hong Kong. My team are running a cohort study in adults. In a minute, I'll show you a cohort study in healthcare workers. I have a cohort study in elderly as well. And one of the things we can do with those is look at the existence of infections in the community that were not diagnosed. In this cohort study, we have almost 2,000 blood samples collected during and after the fourth wave in Hong Kong. And then we looked for antibodies to indicate potentially unrecognized infections, estimating that we did miss some, perhaps 5 times as many as there were cases, but with a lot of uncertainty, of course. But if we have our best guess, we think 1% incidence in the first 18 months of the pandemic, the first 2 years of the pandemic, which is really a fantastic effort in terms of minimizing transmission and minimizing the impact of COVID on people's health. But of course, there's other impacts of the control measures. And in my study on healthcare workers, we also have very good evidence that there's very few unrecognized infections in healthcare workers, despite in some cases that the table inset shows that some of our participants were very heavily exposed, working in the dirty wards, managing COVID patients, and very well protected by infection control, presumably. Of course, some of the patients wouldn't be particularly contagious, but nevertheless, I think this is quite different to other parts of the world where healthcare workers have often had quite high infection rates. In Hong Kong, we haven't had that many infections in the community, and that certainly makes a big difference. The wards haven't been that busy, but the infection control from the SARS experience, the infection control in Hong Kong has been pretty good. Negative pressure isolation rooms for many of the patients, and very good personal protective equipment that's been stockpiled, and people are trained to use it and ready to use it. Now, onto vaccines. We have 2 vaccines available in Hong Kong. We have an inactivated vaccine from the company Sinovac from mainland China, and we have the mRNA vaccine, which is it's called the Pfizer vaccine. It's marketed by Pfizer in the UK and elsewhere in the world. In Hong Kong, it's marketed by a Chinese company called Fosun Pharma. So we have those 2 vaccines and they've been available since February or March. In our regular telephone surveys, we wanted to look and see what was the level of enthusiasm for people to get vaccinated. And in the early days of the vaccination campaign, there was quite a bit of vaccine hesitancy, quite a bit. We were asking people, would you tend to get a vaccine once it's available? We were doing it from middle of 2020 onwards, and there was there was a mix. 60%, maybe more, were okay to get it, and then there were some that were not so keen. There was a big drop in the early days of the vaccine campaign when the elderly were the first priority group, and there were a number of thrombotic-related deaths within a short interval of people receiving particularly the inactivated vaccine, and that put a lot of older people off getting vaccinated. So this is before the vaccines were available. We saw a lot of hesitancy, and not exactly anti-vaccination, which will be orange, not wanting to get vaccinated, full stop. We saw a lot of green in this figure, which is people hesitant, waiting to see what other people do, waiting to see how it goes, and then making a decision of whether to get vaccinated or not. And if things go well, we'd expect most of the green group to get vaccinated, and then just a small fraction that definitely want to. And in December of 2020, this is March of 2021 now, we saw the majority of people unwilling to get vaccinated was actually in younger people. And the hesitancy was highest in younger people. And I think that happened elsewhere in the world as well. The older people relatively more willing to get vaccinated, younger people maybe more hesitant and maybe don't see the need for it, and so on. And so we were thinking about that in particular back in the early days of the vaccine campaign. But for various reasons, the pattern changed substantially in the subsequent months. And so this is what's happened until now. The left-hand side of the figure is what I already showed you with hesitancy, meaning that the enthusiasm for vaccine, the predicted uptake was quite low. But as vaccines became available and used, and there were no other major issues, uptake rose and rose and rose. We're now reached above 80% of our population with at least one dose, more than 70% fully vaccinated with 2 doses, and we have approaching 20% of the population having received a 3rd dose. And there was a big jump at the beginning of this year when we started to see Omicron cases in the community. And that makes a lot of sense that some of that hesitancy disappears once there's an immediate risk. But I want to show you that the next slide may really surprise you. Sorry, oh, crikey. I've missed my slide. I've missed my key slide that's going to surprise you. Oh, crikey. I'm really sorry. Let me get it. This is not the usual seminar where there's a slide missing. All right, here we are. Paste it in the middle of the presentation. Real-time update. All right, this is the real problem for us in Hong Kong. This is our uptake by age. And despite older adults being the priority group, the #1 priority group, starting earliest in February, March of 2021, the uptake has been very low. Fewer than 40% of our oldest, of our 80+ years of age individuals, fewer than 40% have received even 1 dose of vaccination. And that's now posing a very major problem as we face Omicron in the community, because, of course, there's infections in all ages. And whereas in other parts of the world, infections are generally milder in people who've been vaccinated, we have a lot of unvaccinated elderly. Our coverage of above 80%, even up to 90% in some age groups, is very, very good. It's really only the elderly that's been the issue. And that's a problem that hasn't been solved in the last 6 months, and it's now going to pose a real issue for us in Hong Kong now that we have Omicron. I'll just briefly show you some data on antibody levels after the two vaccines, because there's a lot of interest in how the two different vaccines might perform. We have the inactivated vaccine in red and the Pfizer vaccine in blue. Very substantial differences in antibody titers. This is against live virus after the first and second dose. And then the levels of antibody persist for much longer in the blue group, the Pfizer vaccine recipients, compared to those who receive the inactivated vaccine. Separately, we have Tcell data showing that there's reasonable Tcell responses on both, and we expect recipients of inactivated vaccine to do okay, but it's really a very stark difference between the two vaccines. So one of the things my team are doing is third dose trials. This is a trial of a third dose of the Pfizer vaccine in people who initially received 2 doses of inactivated vaccine. And what we see is the Pfizer vaccine gives a very good boost in the lower right-hand side, gives very reasonable level of protection against Omicron in terms of live virus neutralization, maybe not as high as the people who get 3 doses of the Pfizer vaccine, but pretty good. And I think it would be much better than having a booster dose with the inactivated vaccine. So the recommendation in Hong Kong is for people who receive 2 doses of the inactivated vaccine to get the booster with the Pfizer vaccine. Now, the current situation here is that we've had a number of community introductions. First, we had a couple of aircrew who independently introduced BA1 to the community and triggered outbreaks. And these were aircrew who were under the policy of after they land, they need to test at the airport. If it's negative, they can go home to see their family. And they need to stay at home the next day. And the day after, this is the 3rd day, they need to go in the morning to get tested. And then they need to go back home and wait for the test result to be negative. And if it's negative, they're all clear, they can carry on. So it's only a 3-day quarantine, unlike most other people that come into Hong Kong that need to do 21 days quarantine. And unfortunately, these 2 aircrew, they went out on the 3rd day after they submitted their sample. They went out for lunch, and then in the evening, the result came back positive. And it was, they should have stayed at home. Separately, we had a Delta outbreak, and someone on social media made a cartoon of a hamster destroying Hong Kong, because we had an introduction of Delta in a pet shop from a hamster that came from the Netherlands. And somehow there's an outbreak in the hamsters particularly. There's transmission to humans probably more than once. And there's still Delta cases in the community now, although the main problem we have is the last one here, the Omicron outbreak, where there was a transmission event in a quarantine hotel. There was a guest staying in the hotel who's coming to the end, I think the 19th or the 20th day of a 21-day quarantine, and the room next door was empty, and a guest came in and had Omicron and somehow transmitted from one room to the other. And the person who was on their 20th day of quarantine, they left the next day, 21 days out of the community with Omicron, and then it unfortunately spread in the community. So this is our epidemic curve. The second wave, the third wave, and the fourth wave are there, but they're very, very small because, as we've seen elsewhere, Omicron quickly dwarfs everything else. We have a large number of infections already every day. The current policies, the government has thankfully changed the isolation policy so that mild cases do no longer need to be isolated in hospital. They can be isolated at home, and stable cases in hospital can be discharged after 7 days. They can't be discharged earlier, but they can be discharged after 7 days. So there's actually plenty of mild cases still in hospital at the moment, and the quarantine can be done at home as well. The measures that we have in place in Hong Kong are similar to the measures we had in previous waves, which were good enough to stop the previous waves, but not good enough to stop Omicron because the intrinsic transmissibility is so much higher. And we've already had 150 deaths, which is approaching the number of deaths we had in the preceding 2 years, mostly in unvaccinated older adults. But worryingly, this is BA2. Worryingly, we've had 3 deaths in children under the age of 5 already. And that has not been reported so much elsewhere in the world with BA1, for example, or with previous variants. So it's actually quite concerning that there might be some kind of change with BA2 that's resulted in a higher level of severity in young children. My colleagues at the University of Hong Kong have been simulating what might happen, led by Joe Wu. And the prediction is that we're we're heading towards a peak fairly soon, perhaps within 2 weeks. And at the peak, there will be major community disruption and a major pressure on the healthcare system, which is already overwhelmed today. And we still have another 2 weeks to go to the peak. In terms of the projection on the impact of the pandemic, it's difficult because many things could still change within the next few weeks. There was a recent policy announcement yesterday. There was a press conference by the chief executive, and a number of measures were announced to mitigate the current wave to some extent, but also to look forward to the end of this wave and to think about how Hong Kong might be able to go back down to zero when this wave is over. So I don't think it's feasible now to stop this wave from continuing at least to a peak. And around that time, we hit herd immunity, of course, under the restrictions. So not a herd immunity against the R0, but a herd immunity against the effective reproductive number, which is probably about 3. And then the epidemic numbers will come down gradually as long as all the measures stay in place. And the government has this idea of doing repeated universal mass testing, which I think is not completely clear, but I think maybe with the intention to try to get down to zero more quickly. So I put an arrow on the slide. Imagine pushing down that epidemic curve at that point with repeated cycles of universal mass testing of 7.5 million people, 3 cycles initially, but may well need more than that. And then isolating the cases again in special facilities, quarantining the contacts, get back to zero, and then resume the dynamic zero COVID strategy. So that there is, of course, a rationale for dynamic zero COVID to protect public health. I would say there's relatively less public health rationale to go back to zero COVID when the immunity in the population is at a very high level, not only because of the vaccines, but also because of a lot of infections. But there may still be other considerations for aiming to go all the way back to zero and then stay at zero for a period of time. So I'm going to finish. This is my last slide. COVID's still a major threat until immunity reaches a high level, and in many parts of the world, immunity has got to a high level or is getting there now. But I think we still need to be very alert for what happens next. I think when Delta was coming down, when Delta numbers were coming down, we were thinking, would that be towards the end of the pandemic? And then we had Omicron, and now Omicron's coming down. We're thinking, is this going to be the end? I hope so. But I just hope there isn't another variant that comes out that we have to deal with again. In mainland China, the dynamic zero COVID strategy will continue. It's not clear at what point that might change, but there's a lot of speculation in the media that it may be in place for at least another year or maybe longer. And for Hong Kong, our current priorities, we're really busy now trying to figure out exactly what's the level of incidence of infections. In my team of about 70 or 80 people, we have a handful of cases already. So that tells us that the incidence in the community is probably getting up to the single-digit percentages by now. Still got some way to go. We're very interested in severity of BA2, particularly because of these 3 pediatric deaths. And we're very interested in vaccine effectiveness, particularly given in Hong Kong, we have the inactivated vaccines that are used in mainland China and many other parts of the world. And we also have the Pfizer vaccine. So we can look and see, really how do these vaccines perform against severe disease? Seems to be both working very well, and also against milder disease. So with that, I'll finish, and we've still got some time for questions.
Thank you very much, Ben, for a fascinating talk on a huge range of topics. You and your team have done a huge amount of work over the last couple of years. So if there are any questions, please either raise your hands or post them in the chat. Okay, Eliza, would you like to ask your question in person, or do you want me to read your question out?
No, I can ask it in person if you like. Hi, I just wondered whether the 5 children that had, was it 5 or 3? 3, whether they had underlying comorbidities, whether they were immunosuppressed or were they normal? They didn't.
So there's not an awful lot of information in the public domain. There's a 4-year-old, a 3-year-old, and an 11-month-old. and there was one report yesterday that all 3 of them had some kind of disseminated encephalitis. We know the first one was that there may have been a role of delayed care, in the sense that if that 4-year-old, I don't know, difficult to say, but certainly 3 children have died, and it does seem like COVID played a major role. And no underlying conditions in each.
Okay, it's just because we're seeing quite a bit of BA2 in sort of across the southeastern London, but I'm not aware of any increase in paediatric admissions at the moment. But we'll certainly keep an eye on it. Thank you. I really enjoyed your talk.
Thanks, Eliza and Ben. Claire, again, would you like to ask your question in person? We've got time. Yeah, sure. So Claire is asking, how well does the population take to dynamic zero COVID? Do you think that the low vaccination uptake in some groups is due in part to this approach?
Oh, no, so yeah, it's a really good question. There's probably a very long answer I could give. A survey was done on attitudes towards zero COVID in either November or December, and the majority of the population were very enthusiastic in supporting the idea, because there's no COVID in Hong Kong and domestically it's pretty normal. There's a minority of people at that time who were frustrated with the travel restrictions and the lack of a timeline to return to normal. But of course, if there's an older person who's seen the media reports of side effects of vaccination, which I think were maybe unreasonable in the way they were framed, and at the same time, that older person knows there's no COVID in the community, and the government is very confident about the zero COVID policy going well, and very enthusiastic about the idea of having a travel bubble with mainland China. I can understand why there's hesitancy in older people. It's a kind of rational hesitancy, because when there's no immediate risk from COVID, then even if there's a tiny risk from the vaccine, you still tend to maybe wait until there's a more immediate risk, or something else changes. And so I think that the low uptake in elderly, one of the reasons would be because of the zero COVID policy. But at the same time, even with the zero COVID policy, you can have a backup plan and say, if it fails, fingers crossed it won't fail, but if it were to fail, we better get high vaccine coverage in the elderly, because otherwise there's going to be a problem. And unfortunately, that wasn't the way things went. There was a very clear priority for maintaining zero COVID, and maybe less consideration of the possibility that it might fail. Yesterday, the chief executive in her press conference, I'll quote the exact words. She said, "Nobody could have imagined we would have a 5th wave." And so, that if nobody's imagining that there could be a 5th wave, then you can understand why vaccination in older adults, that there'd be other things that the government are focusing their efforts on.
Thank you, Ben. Paul Brown also has, I guess, a similar related question. Paul, do you want to ask?
Yes, thanks. Well, it's basically, I think you answered a lot of it there already. But I'm just kind of curious as to why there's a difference between the elderly and, say, adults, working age adults, and more middle-aged, as why that might be. Is there any sense of, what was it due to a policy to target vaccination more at working age, or was it due to just that group's own choice, as it were?
So if I could go back, I mean, there was a lot of hesitancy in all age groups, but there was relatively more effort made to promote vaccination in working age adults through at least in the last 2 to 3 months, the announcement of a vaccine pass system. It's a vaccine passport system. And so for working age adults, and also for older children, there's a lot of pressure to get vaccinated. But for older adults, particularly those in residential homes, in elderly homes, there's no equivalent, because if the elderly person is in a home already, there's no need for a vaccine passport in that sense, because they don't leave the elderly home. So that would be a reason how we got to 90%. But even without those schemes, I think the coverage was going well above 60-70% in the middle-aged adults, the working adults, even without a passport.
Okay.
Thanks. And we have another question from Lin Wang. Would you like to ask in person?
Hi, thanks for your nice talk. I think recently there were some reports on the vertical transmission within the same building, and those new findings were not observed in previous waves. So do you have some opinion on this problem?
Yeah, so I got it on the very bottom of this slide here. In the middle of this figure, in our fourth wave in Hong Kong, the government in Hong Kong had this brainwave for an additional measure to try to stop transmission. And whereas they'd previously been doing the isolation of cases and the tracing of their contacts, they added in an extra step, which was the building where the person lived. And most people in Hong Kong live in blocks of flats. So the apartment block, everyone would get tested. And they'd even go there at maybe 7 p.m., barricade off the entire apartment block and tell everybody they got to be tested in order to be able to leave home the following morning. And so everyone got tested. And in the fourth wave, about a year ago, those exercises found very, very few cases. So it was actually very good quality scientific evidence that there wasn't transmission going on in the residential apartment block, other than perhaps with friends and people that knew each other that happened to live in the same building. But right now in our current epidemic, we've seen a number of very large outbreaks in residential apartment blocks. The sequencing indicates that it's the same strain, but actually there's only a few introductions. So we can't be sure exactly how that transmission's occurred, but it seems to be spreading through the air, maybe in the central parts of the apartment blocks, going up and down outside the bathrooms or whatever when people have open windows. But it's a really interesting question to work out why this is happening with Omicron, and it didn't happen before, that suddenly it seems to be much more contagious, and we do now have these residential outbreaks. So the largest that I'm aware of is, I think, 200 or 300 cases found in a very short space of time in a single apartment block. And that's remarkable, because that's a very substantial outbreak, potentially triggered by just a handful of cases in the building. So we're trying to work out what might have been happening, but there's not a lot of data to go on in terms of figuring out the exact transmission dynamics, but it's certainly an interesting phenomenon.
Thank you, Ben. We have another question from Charlotte. Would you like to ask in person?
Hi, thank you. Yes, absolutely fascinating talk. Obviously, so interesting with the current changes in the UK at the moment. And the expectation to continue this dynamic zero COVID for another year or more. I do wonder about the thoughts of an ultimate exit strategy for Hong Kong. I don't know if you can comment on that.
Well, so in the mainland, there's no announcement about when or how they might stop the dynamic zero COVID strategy and transition away from it, because I don't think it's the kind of strategy that would be there forever. But in Hong Kong, there's an attraction towards the idea of being able to have quarantine-free travel across the border, because many people in Hong Kong have work reasons or personal reasons to travel into the mainland. And in our population of 7.5 million, we used to have 300,000 people crossing the border every day with the mainland. That's a lot of people going backwards and forwards every day. So that's an attraction, and that would still be an attraction for zero COVID even after a large Omicron wave. But I'm not sure if Hong Kong goes back to zero COVID, I suppose then the exit for Hong Kong would be whenever the mainland decides to exit, and that is not clear. But different people have different ideas about when that might be, but certainly not in the short term.
Thank you.
Thanks. Charlotte Hammer, would you like to ask your question?
I realized that was pretty much exactly the same question as the one that was posted a few seconds before mine.
Okay, thanks. Eleanor.
Hi. This is a question not really based so much on your data as your perceptions from living and working in Hong Kong. And I wondered if you could say something about the strategy that was taken there and whether you think it could have worked in a country like this if we'd been ready for it.
In the UK? Mm-hmm. Yeah, I think it's difficult. So there's two components of zero COVID that I think are difficult. The first one is the outbreak control phase. And I think in the UK, there was a study I heard about that said, if the measures had been kept in place in the first wave, and we kept in place for a little bit longer, it might have been able to get all the way to zero. I can believe it, but that was an enormous amount of effort to stop things. The contact tracing in the UK hasn't been that easy, so it's relied more on social distancing than maybe targeted measures. For the next pandemic, maybe it would be a little bit easier to do the contact tracing, but still the social distancing is very disruptive. I think the second phase would be my concern for the UK. How could you insist on arrival quarantines for anyone coming into the UK? Because if you don't have that, just one case in the community can already trigger an outbreak potentially. And if you domestically, you've relaxed all the social distancing, then it won't take long. So if you look at what happened in Melbourne, it was actually very tough for them because they had to spend a lot of time in lockdown. They had a number of leaks of infection into the community. And every time there was a leak, it was pretty difficult to stop it. So for the UK, I'm not sure with current infrastructure, but obviously if there was an even more severe pandemic in the future, it would be something to consider because the UK is an island, at least. It's not like a European country surrounded by lots of others. But it's not easy. And I think Singapore had a very sensible idea when they said they can hold on to zero COVID, the first 18 months, but once vaccine coverage gets to a high level, they're not going to do it because it's just too difficult and costly to sustain in the longer term. And once vaccine coverage reaches a high level, it's relatively not as justified. But I think the first 18 months, it was a really good strategy for Hong Kong. It worked really well, and Singapore as well.
Thank you.
Thank you, Ben. And I think we're out of time now. So apologies, David, who asked another question in the chat, but perhaps Ben can answer on the chat afterwards. But I think we will end here. Thank you very much, Ben. It was a fascinating talk.
Thank you.